Dr. Versace, as someone who appreciates stylish diamonds, it's an honor to meet the man whose last name conveys the highest levels of tasteful excellence. Do you have any relation to Gianni Versace, by the way?
Look, it's all the same family, but when Gianni died, he left everything to Donatella, so I don't talk to him anymore.
Good to hear indeed. Well, Dr. Versace, I'm just wondering if you can go ahead and share your presentation. We're looking forward to hearing it.
So I'm going to talk about the Femtus lens. This is the concept of a lens that attaches to the anterior capsulorhexis. And now it's interesting to think about this because you would think that by now we'd have cataract surgery perfected. We've been doing it for long enough, but there are still problems to be resolved. We still have unwanted visual phenomena. We have dysphotopsias, we have glare and halos. And we're still not really able to adequately center a lens and to get a predictable effective lens position. So it would be nice to think we can resolve these issues. This style of lens, the Femtus rhexis fixated lens, is from Teleon. It's based on an existing lens platform. There's a family of lenses that share this concept, which is the concept of an asymmetric refractive design. It's an EDoF lens attached to the anterior capsulorhexis, and it's also a toric lens. We talk about centration all the time, and it's a word that gets bandied around but doesn't mean very much unless we really talk about the reference points. What really matters for a lens implant is centration with the visual axis. That's what's going to affect the quality of vision with a lens implant. And for the various markers we can use as we talk about centration, it's the visual axis we want to talk about, but that's not always so easy to measure and determine. Angle kappa relates the visual axis to the center, to the pupil. And this is very useful for refractive surgery, but really not useful at all for lens implantation. Angle alpha is the mark we should talk about with lens implantation, because this correlates the position of the visual axis with the limbus, which pretty well equates with a capsular bag, which is where an intraocular lens will center. So angle alpha allows us to talk about the centration of an intraocular lens with the visual axis. The eye trace is a useful tool for looking at this, and we can see with the lens I'm talking about, this asymmetric segmental design, it's really quite forgiving in terms of the visual axis position, because you've got a large area where you've got a refractive element that will work. It's only if you are unlucky enough to have the visual axis impinge upon the junction between far and near that you're going to get a problem with this. Negative dysphotopsia is something that occurs and often goes unreported. When it's studied carefully, it's reported that up to 3% of patients will experience negative dysphotopsias long-term, and they hate it. So there's a bit of vision missing, and it's always peripheral, and it's a dark crescent. That's why it's a negative dysphotopsia. Some patients just report it, and it's like, well, I want you to know about it. It doesn't bother them. For other patients, it drives them crazy, enough so that we will want to treat it. Treatments for it? Well, in the end, piggyback lens will help, reverse optic capture, even exchanging the lens is sometimes done. But to me, I would prefer to be able to use a lens design that pretty much eliminates negative dysphotopsia. And the best way to achieve that is having a lens that's close to being in the plane of the anterior capsule and to minimize the space between the back of the iris and the anterior optic surface. With the Femtus style of lens, the lens is actually in the plane of the anterior capsule. So it's placed within the capsulorhexis. And so far, in all the studies that have been done of this lens, we've had one published, and Gerd Orfard's group in Europe had one published early this year, and there are no cases of negative dysphotopsia reported. So it probably does eliminate it. There are other lenses we have available now, specifically designed to eliminate negative dysphotopsia. Sam Maskett has a lens that has a flange around the edge of the optic into which the anterior capsulorhexis is placed, specifically to try and avoid negative dysphotopsia. This lens has been around for a long time from Marie Tassignon. It's designed so that you can have the anterior and posterior capsulorhexis placed into a flange in the edge of the optic. This is specifically for pediatrics and probably not generally applicable for us. More recently, we had a novel design come out of India, where we have these little flanged hinges that move out and are placed in front of the anterior capsulorhexis once the lens is implanted. Again, with the aim being to put the lens in the plane of the anterior capsule and eliminate negative dysphotopsia. The lens I use is the Femtus. This is an easy lens to use. It has 4 flanges that attach to the anterior capsulorhexis, and one of its benefits to me is we pretty much eliminate negative dysphotopsia. The lens is implanted through a standard wound, 2.2 millimeters. It's folded and it goes into the capsular bag. I remove viscoelastic from behind the lens just to be sure I'm not going to get a capsular bag syndrome. Having done that, I put a bit more viscoelastic in front of the lens to protect the endothelium. Then each of these 4 fine flanges is lifted forward to enclavate the lens, to attach it to the anterior capsulorhexis. This probably adds 40 seconds to the surgical time, so there's really no impost with using this lens. And it's very easy once you work out exactly how you're going to go about doing it. We did a study which was published 2 years ago now just to look at some aspects of the lens. And there are 2 distinct aspects to think about. One is the mechanical, physical aspects, the idea of a lens being attached to the anterior capsulorhexis. And secondly is the concept of the EDoF properties of the lens, how it performs and the sort of visual performance it gives patients. This was 50 eyes prospectively studied using a catalyst laser to create a capsulorhexis, looking at visual outcomes and also mechanical and physical outcomes. Refractive predictability is excellent. We had not more than 90% of our patients within half a diopter. That's what you would expect for any good quality lens. I would expect that with bigger numbers, we would see better refractive predictability with this lens design than with normal in-the-bag lenses. We have a more predictable effective lens position, so it makes sense that we will get more predictable refractive outcomes. The refractive outcome is stable over time. And importantly, when we look at patients being able to achieve 6.6 and N6, we have about 70% of patients who get these values, so the lens should give functional vision. The lens truly behaves as an EDoF lens. You may conceptualize it as a bifocal lens with 2 refractive elements, but its performance on a defocus curve is that of an EDoF lens, and very closely mimics that of the Symphony, but with an extension of the range of focus. In our study, we had 60% of patients who never wore spectacles, completely spectacle independent. The other 40% sometimes wore reading glasses. Importantly, this is probably the main point of this style of lens, is that we can achieve this kind of functional vision, but without the unwanted visual phenomena. This is a tool we've been using for many years now to subjectively quantify the halos and glare that patients will get over a number of lenses. On the very left-hand side is the average patient with the MF15 or MF20, the refractive segmental style of lens from Teleon, and they get minimal impact on their night vision quality. Whereas with all the other lenses, with any other diffractive lens, they get halos. If we represent that graphically, on the far right is what we found for the Femtus in our study. So it has minimal unwanted visual phenomena as compared particularly with the diffractive multifocal lenses that we have used and measured with the same device. Subjective questionnaire closely mimics this outcome so that no patient had any kind of problem that went anywhere close to being an issue in terms of subjective impairment of visual quality.
Just to mention that slide there, it was an interesting one to me because we saw unwanted visual phenomenon. They're there, but they're within the good range, it appears. Is that right?
Right. Well, it's hard to represent some of these things when you've done a subjective questionnaire to represent them on a graph. And so here, basically, 100's bad, 0 is good. And it's just to make the point that everyone's going to have something. You know, sometimes you get a bit of dry eye, sometimes a little bit of glare if the sun's shining in your eyes. But for someone to score 10 when 100 is bad, that's all just like noise, really. Yeah, but it's a good point. The second aspect of the lens, which is really interesting, is the physical aspect, the idea of attaching it to the anterior capsulorhexis. What does that do? Does it give any benefit? And we looked at that. Certainly, we don't get phimosis. And again, with our study, with the collaborative European study, there are no cases of capsular phimosis seen. We get these beautiful, clean capsules that you can see 6 months, 12 months after surgery. There's no question in my mind that having the lens in the capsulorhexis really controls how the anterior capsule behaves with time. And certainly there's no mechanical forces causing the lens to move. So that we had a median shift in the lens of only 90 micrometers over 6 months. So it's just noise. In other words, once you place that lens aligned with your visual axis in the anterior capsulorhexis, that's where it will stay. It won't move as the capsule contracts after surgery. Now, of course, this necessitates a technique for doing a perfect capsulorhexis of a known circularity, size, and alignment. So we have to think about how we do that. Do we all have to use expensive femtosecond lasers? Well, I've done this manually. Now I'm going to say you can do it manually, but no, you can't do it manually. And being able to always create exactly a 5mm Capsulorhexis that's perfectly circular and perfectly aligned with the visual axis, yeah, you'll do it sometimes, like this time when I managed to do it, but you won't do it every time. So I think that manual Capsulorhexis is not the solution. Zepto maybe is something useful and it avoids having to buy an expensive femtosecond laser, but this is not an easy device to use. It's quite cumbersome inside the eye, and I expect we will be seeing some complications with the use of Zepto. What I'm pretty excited about right now is the use of Capsulaser. Capsulaser allows me to create a perfectly circular Capsulorhexis of a known size that is up to 3 times as strong as what I can achieve with a femtosecond laser. I think that's a good match for the Femtis lens. There's a very nice paper published by Shiraz Dyer's group 2 years ago now that showed that the Capsulaser can create a Capsulorhexis that's much stronger than both a manual Capsulorhexis and also that created by the femtosecond laser. And that's because the edge of the Capsulorhexis shows this sort of congealed rolled rim of collagen, which is smooth and strong, as compared with the bottom image, which is that of a femtosecond laser Capsulorhexis, where you have the kind of perforated appearance that can tear out. Now, as I finish, I'll say that this lens design attached to the anterior Capsulorhexis lends itself to a toric lens. Once the lens is enclavated, attached to the anterior Capsulorhexis, it can be rotated. And you can place it exactly where you want it, and it will stay there. There's no bounce, there's no movement as those haptics compress and re-expand. So I think as a toric, this is going to give us accuracy of alignment like we've not been able to achieve before. So in summary, I think that the concept of the capsule fixation of a lens makes sense. We can probably eliminate dysphotopsias. We can align with the visual axis. We can prevent capsular contraction syndromes. With enough numbers, we'll be able to demonstrate, I think, that there is more refractive predictability because of the effective lens position being a more known quantity. Tilt is significantly reduced. And with the EDoF design, we can really minimize any unwanted visual phenomena that we may see with other forms of EDoF lenses. So I think this is a compelling technology, and I'm going to use it more and more.
Well, Dr. Versace, to use the language of diamonds, I think your lecture was crystal clear.